Today I will be discussing about the vertical papillary lesions, the connective tissue lesions, and the lymph node lesions. Vertical papillary lesions. So it is in reactive lesions. It has a papillary hyperplasia, condyloma latum, squamous papilloma, condyloma acuminatum, focal epithelial hyperplasia, neoplasms, keratoacanthoma, varicose carcinoma. So, unknown etiology: fused stomatitis vegetans, vericiform xanthoma, the varicose leukoplakia. So, the varicose carcinoma, its differential diagnosis: SCC, proliferative varicose leukoplakia. Its treatment is surgery followed by radiotherapy. So, papillary hyperplasia. So, etiology: immovable dentures, hard palate, and trauma. Microorganisms are the candida. Papillary hyperplasia and clinical features: site, palate, erythematous papillary cobblestone, ulceration is rare. In its histopathology, small papillary projections covered with SSE, stroma is well vascularized, epithelium is hyperplastic with pseudoepitheliomatous features, no evidence of hyperplasia. So as you can see here in the picture, it shows the epithelial dysplasia, the mild, moderate, and severe. Then it's a malignant invasion of epithelium, the pseudoepitheliomatous epithelium. So next, papillary hyperplasia, its differential diagnosis is nicotine stomatitis, multiple squamous papillomas, acanthosis nigricans, Cowden syndrome. Its treatment and prognosis is mild, soft tissue agents and liners, and surgical removal. The condyloma latum, its etiology secondaris filus, clinically most common in the perianal area, orally, smooth, lobulated or mushroom-like mass, HP, acanthosis, intra and intercellular edema, inflammatory cell infiltration. Its treatment is, it will regress after the treatment of syphilis. Next is squamous papilloma, oral varicose vulgaris, etiology, HPV is 2, 6, 11, 57, 2, 4, and 40, cutaneous verruca, 3 and 10, flat warts, 13 and 32, focal epithelial hyperplasia. Transmission might be through direct contact. The squamous papilloma clinical features is most common papillary lesion of the oral mucosa, palate, lip, and vermilion, and other parts of oral mucosa, generally single and less than 1 cm, cauliflower-like surface. So, like this picture. So, squamous papilloma, its histopathology is growth of keratinized squamous epithelium, well-vascularized trauma, inflammatory cell infiltration. Yes, so its differential diagnosis is vericiform xanthoma, the gingiva, skin, Langerhans, condyloma acuminatum, it's larger with broader base. Terrier's disease, it's multiple. So the squamous papilloma treatment is by removed by surgery or laser. Condyloma acuminatum, so its etiology, it's cauliflower-like, and HPV 6 and 11, infectious lesion, frequent in HIV ineffective persons. The condyloma acuminatum clinical features is common in the anogenital region and may involve oral mucosa. Early stage, multiple pink nodules. Later it grows and coalesces to become soft, broad base papillary growth. Condyloma acuminatum, its histopathology. So, papillary projections covered by hyperplastic SSE might be keratinized or non-keratinized. Upper level of epithelium demonstrate perinuclear cellular vascularization, the koilocytic cells. Vascularized trauma with inflammatory infiltration. So, as you can see in that arrow is the koilocytic cells. Next one is the connective tissues. So, connective tissue lesions. Fibrous lesions, reactive hyperplasia, fibrous hyperplasia or exuberant, proliferation of granulation tissue is peripheral fibroma, generalized gingival hyperplasia, denture-induced fibrous hyperplasia, and its neoplasms, heterogeneous that form complex collection of disease, the myxoma and sarcoma. So, fibrous lesions, it's peripheral fibroma, etiology, reactive, secondary to overexuberant repair. Its origin is connective tissue of the submucosa. Clinical features is predilection for young adults, female, male. Location, commonly at the gingiva, anterior to molars, similar in color to the surrounding tissue. Connective tissue lesions, fibrous lesions again, and in peripheral odontogenic fibroma. In connective tissue lesions, fibrous lesions in focal fibrous hyperplasia, it is common in frequently traumatized area. So, in peripheral fibroma, histopathology, focal fibrous hyperplasia, highly collagenous and relatively avascular, mild to moderate inflammatory cell infiltrate subtypes, peripheral ossifying fibroma, peripheral odontogenic fibroma, giant cell fibroma. Differential diagnosis, pyogenic granuloma and peripheral giant cell granuloma. Treatment, local excision. So, again, in peripheral ossifying fibroma. Connective tissue lesions, fibrous lesions in generalized gingival hyperplasia. Its definition, the overgrowth of the gingiva. Its etiology is non-specific, response to chronic inflammation associated with local factor. Hormonal changes is imbalance. Drugs, phenytoin, cyclosporine, and nifedipine. Leukomia. So, generalized gingival hyperplasia, its clinical features increase in the bulk of free and attached gingiva. Stippling is lost, color is red to blue, and associated inflammation is non-specific factors, and hormonal imbalance appears more inflamed than drug-induced hyperplasia. Histopathology, abundance in collagen, increased number of fibroblasts, various degrees of chronic inflammation, increased capillaries hormonal, and immature and atypical white blood cells with leukomatic type. So, it's connective tissue lesions, fibrous lesions in gingival fibromatosis. Connective tissue lesions, fibrous lesions, generalized gingival hyperplasia. Treatment is attentive oral hygiene is necessary, and gingivoplasty or gingivectomy in combination with prophylaxis. Connective tissue lesions, fibrous lesions in denture-induced fibrous hyperplasia. Its etiology is chronic trauma produced by an ill-fitting denture.
Clinical features occurs in the vestibular mucosa, over-exuberant fibrous connective tissue, a reparative response, and painless folds of fibrous tissue. Treatment, surgical excision is usually required.
So this picture shows the epulised fissuratum. So, in connective tissue lesions, fibrous lesions in neoplasms, myxoma, benign proliferation of spindle cells. Clinical features, it is soft neoplasms composed of gelatinous material. It is slow growing, asymptomatic. Its location is on the palate and occurs at any age. Connective tissue lesions, fibrous lesions in myxoma, histopathology is not encapsulated, may exhibit infiltration into surrounding soft tissue, dispersed stellate and spindle-shaped fibroblast, loose myxoid, and myxoid stroma. So, connective tissue lesions, fibrous lesions in myxoma, treatment is surgical excision, and recurrence is not uncommon. Connective tissue lesions, fibrous lesions, and fibrosarcoma, it is a malignant spindle cell tumor showing interlacing fascicular pattern. Clinical features can arise in bone. Young adults most commonly affected, and it is considered as infiltrative neoplasms. Connective tissue lesions, fibrous lesions, fibrosarcoma, histopathology, collagen sparse, frequent mitotic figures. Third, defined periphery. So here, it shows the treatment of fibrosarcoma. It is wide surgical excision, and recurrence is not uncommon. Metastasis is infrequent. 5-year survival rate is 30 to 50%. Next one is, let's talk about the lymphoid lesion. The lymphoid lesions, reactive lesions, is the lymphoid hyperplasia and angulymphoid hyperplasia. Its developmental lesions is lymphoid epithelial cyst, and neoplasms, the lymphomas, and Hodgkin's lymphomas, non-Hodgkin's lymphoma, and myeloma or the plasmacytoma. So it's reactive lesions, lymphoid hyperplasia. Normal lymphoid tissue in around the oral cavity. the pharyngeal tonsils, lingual tonsils, oral tonsils, regional lymph nodes, and lymphoid tissue. So first, the LH is a proliferation of lymphocytes without a cytological atypia. Mitotic figures often remain restricted to the germinal center. Occasionally, it may mimic the Serri appearance. The follicular lymphoid hyperplasia is a reactive condition involving the soft tissue covering the hard palate, the lymphoproliferative disease of the palate, similar to follicular lymphoid hyperplasia but always associated with malignancy. Angulymphoid hyperplasia with eosinophilia, epithelioid or histiocytoid hemangioma. So, nodular subcutaneous benign disease, aggregates of lymphocytes and eosinophils, regional lymphadenopathy, and a blood eosinophilia. So, ALHE clinically, oral mucosal involvement is rare. However, it is common in the head and neck area. If we cure, labial mucosa is the common site, predominant in males, affect persons in all ages. 1 to 2 cm, solitary painless mobile lesion that enlarge gradually. ALHE histopathology is well-developed lymphoid follicles containing germinal centers and proliferating and dilated capillaries. And lastly, the intensive infiltration of a lymphocyte with eosinophils and fewer number of macrophages. Treatment, surgical excision, and intralesional steroid injections might be effective. Kimura's disease, similar to ALHE but without the association with regional lymphadenopathy, different but related entity. Developmental lymphoepithelial cyst. Developmental lymphoepithelial cyst, neoplasm, Hodgkin's lymphomas, non-Hodgkin's lymphomas. The Hodgkin's lymphomas is affect the bone or soft tissues, painless enlargement of lymph nodes or extranodal lymphoid tissue, rarely affect the oral cavity, malignant lymphoid cells, non-neoplastic inflammatory cells, Reed Sternberg cells. Luke's Bolter histology classifications. First, the lymphocytic predominance, nodular sclerosis, mixed celerity, lymphocyte depletion, and Arbor classifications. Stage 1 is involvement of single or single extralymphatic system. In stage 2, 2 or more LN chains. Stage 3, positive disease in both sides of diaphragm. Stage 4, bone marrow, liver, or other extralymphatic organs. Treatment and prognosis. External radiotherapy and chemotherapy. Non-Hodgkin's lymphomas, the middle-aged and elderly gradual, asymptomatic focal enlargement of lymph nodes, and Arbor classification. First, the nodular lymphoma, 3 subtypes. These are the poorly differentiated mixed lymphocytic, histiocytic, least favorable prognosis. Second, diffuse lymphoma, the lymphocytic. It is well differentiated, poorly differentiated, and histiocytic mixed. So its treatment, stage 1 is radiotherapy and other stages is chemotherapy or both. The Burkitt's lymphoma, non-Hodgkin's lymphoma, African children lymphoma, translocation of distal part of chromosome 8 to 14. So translocation of long arm of chromosomes 22 to 9 is called Philadelphia CHR leukemia. So its highest proliferation rate in humans. Clinically, persons of all childhood malignancy mean age, race, show involvement association with ABV. So here in persons of all childhood malignancy, in African it has a 50%, and in American it has 6 to 10% in mean age. In African 3 to 10 years, and in American 11 years. Its race is they has a 100 blacks, and in American 77% whites. The joint involvement in African relatively common and American are uncommon. So in association with EBV, in African it has 90% and in American it has 10%. So radiographically, poorly marginated radial sensory cortex expanded, eroded, or perforated. Histopathologically, B-cell proliferation, nodular or diffuse proliferation, proliferation of lymphocytes with numerous scattered macrophage, sericious. The treatment and prognosis, chemotherapy, and 2-year survival. The plasma cell neoplasms, multiple myeloma, solitary plasmacytoma of bone, multiple myeloma. What is plasma cell? So, may present in soft tissue or in bone, solitary or multiple. 80% of bone plasmacytomas involve head and neck region. Mean age 60 years. May be asymptomatic in symptomatic cases, pain, swelling, expansion, numbness, or mobility of teeth, a loss of weight, and anemia in some cases. Immunoglobulin components, so IgG and IgA, may be detected in serum and urine of 91% and 97%. Radiographically, 85% of patients have abnormal radiographic skeletal survey and multiple well-defined radiolution areas. Histopathology, proliferation of plasma cells, treatment and prognosis, chemotherapy and steroids, and local radiation. Most patients die of infection or renal failure. Mean survival in 2 to 5 years. In solitary plasmacytoma of bone, mean age 50 years, rarely affect jaw angle of the mandible. It may progress to multiple myeloma. Radiographically well-defined radiolucency, it may penetrate the cortical bone to the adjacent soft tissue. Peripheral blood picture is normal. Bone biopsy reveals proliferation of plasma cells, producing immunoglobulin components. Treatment is local radiotherapy. Survival of patients is 10 years.